Imagine you've just finished a really long, demanding week.
Yeah, we've all been there.
Right. And you're sitting on the couch and you feel this deep, aching pain right between your shoulder blades.
Just kind of creeping up on you.
Exactly. You're overwhelmingly exhausted, maybe, a little nauseous, and your brain immediately tells you that it's just stress.
Which makes sense. I mean, you think you just need a nap.
But inside your chest, a cascade of microscopic events has just tipped from, like, a warning into a lethal crisis. Your heart muscle is actively starving to death.
It's a terrifying thought, honestly.
It really is. Today, we are looking at the mechanics of a heart attack, or myocardial infarction.
And the numbers on this are staggering.
Yeah, they really are. Every year, 800,000 individuals experience an MI, and 370,000 die from coronary artery disease. So this isn't just some random medical topic.
Yeah, that's not.
It's a survival guide. We are using a comprehensive medical text on cardiac disorders, specifically Chapter 32 on angina and MI.
It's dense material for sure.
Yeah, super dense. But our goal for this deep dive is to shortcut your path to being well-informed. We want you to know how to recognize, understand, and practically navigate a heart crisis while completely bypassing the jargon.
Because honestly, whether you're prepping for a health science meeting or studying or just insanely curious about how the human body works, this is vital.
Yeah, understanding these mechanics might just save your life or the life of someone you love.
Absolutely.
And to help us connect all these clinical dots, I'm thrilled to introduce our resident expert, who is basically a master at synthesizing this stuff.
Oh, well, thank you. I'm excited to be here. Because we're not just going to explore what happens during a heart attack. We need to look at why it matters.
Right.
From the microscopic cellular level all the way out to the actual social environment of the patient. Because it really is a race against time at a cellular level.
Okay, let's unpack this. The core concept here is the difference between angina pectoris and a true myocardial infarction.
Right. They're clinically very different things.
So let me try an analogy on you. If the heart's blood supply is a garden hose, is angina just like a temporary kink in the hose, whereas an MI is the grass actually dying from lack of water?
Oh, that's actually a perfect way to look at it. Yes. Angina is caused by ischemia.
Ischemia, right.
Yeah, which it just means decreased perfusion, usually due to atherosclerosis. There's a kink in the hose, but it's reversible.
The grass is just a little dry?
Exactly. But an MI, a myocardial infarction, that results in tissue necrosis. The grass is dead, and cardiac muscle doesn't regenerate, so that damage is permanent.
Wow. Okay, so looking at the source text, there are a few different ways that hose can get kinked. It lists 3 types of angina.
Right, and they behave differently.
So the first is stable angina. This is exertional, right?
Yeah, like when you're exercising.
Yeah.
The heart needs more oxygen, but the artery is narrowed.
But the key is that it's relieved by rest or taking nitroglycerin.
Exactly. You sit down, the demand drops, the pain goes away.
But then there's unstable angina, which the text calls pre-infarction.
And this is where it gets scary. Because this happens at rest or with very little exercise, and it increases in severity over time.
It's essentially the alarm bell right before the grass dies.
Exactly. The plaque in the artery is becoming unstable and forming temporary clots.
And then the third type is variant, or Prinzmetal angina, which is weird because it's not even a physical blockage, right?
Yeah, it's caused by a spasm in the coronary artery. It just clamps down, often when the person's just resting or sleeping.
So if angina is the warning system, you really need to know exactly what the alarm looks like when it stops being a warning and becomes an acute emergency.
Right, you need to know when the grass is actually starting to die.
Which brings us to the myth of the Hollywood heart attack.
Oh, I love talking about this.
Right, because we always see the guy clutching the center of his chest, wincing, grabbing his left arm. Does it really always happen like that? Like, what if the pain just feels like heartburn?
What's fascinating here is how wildly different the manifestations are based on biological sex and age.
Really? It's that different?
It's completely different. Males do often experience that classic chest pressure radiating to the jaw or arm. But females and older adults frequently exhibit completely atypical symptoms.
Like what? What should people look out for?
Things like pain between the shoulder blades, extreme fatigue, syncope, which is fainting, or even just severe indigestion.
Wait, fainting? From a heart attack?
Yeah, literally just passing out.
Yeah.
Or an exhaustion so deep you can't even stand up.
That is so deceptive.
It is. Think about it. If you're listening to this right now, what stands out to you about these atypical symptoms? How easily could extreme fatigue just be brushed off as a long day at work?
I'd probably just go take a nap, honestly.
Exactly. which is why the source emphasizes a really critical diagnostic rule, the 15-minute rule.
Okay, what's that?
If you have chest pain or back pain or whatever the symptom is, and it is unrelieved by rest or nitroglycerin, and it lasts longer than 15 minutes,
Then it's not just a warning anymore.
right, that is the primary differentiator separating angina from a true MI. You have to assume it's an emergency.
But since the symptoms can be so vague, the doctors can't rely on patient reports alone, right? They need objective proof.
They have to see the damage happening.
Right, which leads us directly into how the hospital actually spots a heart attack. Decoding the damage. Let's talk about the electrical map, the ECG.
The electrocardiogram, yeah.
The text lists some very specific warning signs here. ST depression or a T-wave inversion means ischemia.
Basically, the heart is struggling. It's that reversible kink in the hose.
But an ST elevation means severe injury. That's the STEMI, right?
Yes, ST elevation, myocardial infarction. That's the big one.
And if they see abnormal Q waves, that means actual tissue death has occurred. The grass is dead.
Exactly. It's a permanent electrical scar.
But wait, I have a question about this. The text mentions NSTEMI, non-ST elevation myocardial infarction.
Yeah.
So if I hear NSTEMI, does the N mean no big deal? Like, since there's no ST elevation, is it just a mild warning?
No. That is a huge misconception.
Yeah.
And STEMI is still acute coronary syndrome, and it can absolutely be lethal.
Really? Even without the elevation on the monitor?
Yes. It just means the damage might be partial thickness or happening in an area the ECG leads aren't picking up clearly, but the tissue is still dying.
So how do they catch it then?
If the electrical map is hiding it, you have to look deeper into the blood. You look for the chemical alarms.
The cardiac enzymes.
Right. When cardiac muscle cells die, they physically burst open, and they leak very specific markers into the bloodstream.
Okay, let's go through the timeline of these markers. The earliest one is myoglobin.
Yeah, myoglobin shows up fast, about 1 to 3 hours. But it's not super specific to the heart.
Because any muscle damage can cause it.
Exactly. Then you have CKMB, which peaks around 24 hours.
But the big one, the text says this is the gold standard, is troponin. Troponin I and troponin T.
Troponin is the undeniable proof. It is completely specific to cardiac tissue. If it's in the blood, heart cells have died.
And what's the timeline on that?
It starts elevating in 4 to 6 hours, but the crazy part is it sticks around for up to 10 days.
Oh, wow. So even if you try to tough it out at home for a week, they can still catch it.
They will know. The blood doesn't lie.
So once they confirm it, what other tools do they use? The text mentions a thallium scan.
Yeah, they inject a tracer, and the dead tissue shows up as cold spots on the scan because no blood is flowing there.
But you have to avoid caffeine before that, right?
Right, for at least 12 hours. Or it completely skews the blood flow results.
And then for a really direct look, there's cardiac catheterization or angiography.
Where they thread a catheter right up into the heart and inject a contrast dye to see the exact blockage on an X-ray.
Though, fun fact from the text, you have to check for an iodine or shellfish allergy before doing that.
Yes. The contrast dye has iodine. You do not want to trigger anaphylaxis while someone is having a heart attack.
Talk about a bad day getting worse. So, okay, now the medical team has confirmed the heart attack. They see it. What happens in those critical next minutes to actually stop the damage?
This is where they deploy the immediate defense line.
The ME-MONA protocol, I love a good acronym, morphine, oxygen, nitrate, aspirin.
It's the standard of care for a reason.
Here's where it gets really interesting, though. Let's look at the specific mechanics, starting with nitroglycerin. It dilates the coronary arteries to get blood flowing.
Right, it opens the pipes up.
But there is a wild contraindication in the text. You absolutely cannot give it if the patient has taken a phosphodiesterase inhibitor like Viagra for erectile dysfunction within the last 24 to 48 hours.
Oh, yeah. That combination is incredibly dangerous.
Because it results in severe hypotension, right?
Yes. Both drugs are profound vasodilators. If you combine them, the blood vessels dilate so much that the blood pressure completely tanks. It can be fatal.
That is such a specific but crucial thing to know. What about the aspirin and MNA? Why chew an aspirin?
Well, aspirin inhibits specific enzymes called KOX1 and KOX2.
Which do what exactly?
They tell platelets to clump together and form clots. So the aspirin basically blinds the platelets, preventing the clot that's blocking the artery from getting any bigger.
Got it. And the M in MNA, morphine. Obviously, that's for the pain.
It is, but it's a dual role. Morphine also decreases myocardial oxygen consumption.
How does a painkiller do that?
It relaxes the patient, lowering their adrenaline and heart rate, which means the heart doesn't have to work as hard. Though you do have to watch out for respiratory depression. It can slow breathing down too much.
Okay, so MNA stabilizes them. What's the ongoing arsenal? What happens next?
Well, they'll use beta blockers like metoprolol to keep the heart's workload down.
But the nurse has to hold the med if the heart rate drops below 50 beats per minute.
Exactly. You don't want to slow it down too much. Then there are thrombolytics. These are the actual clot busters like alteplase.
But those have a strict time limit.
Yeah, they have to be given within 6 hours of the infarction to be effective. And they'll also use anticoagulants like heparin just to keep the blood thin.
It's honestly a marvel of modern medicine. The precision of the ER response is incredible.
It really is.
But there's a glaring reality in the source material. Surviving the ER is only half the battle. What happens when the patient goes home?
This is where clinical medicine hits the real world.
Yeah. The text introduces this really poignant scenario. Imagine a patient returning to the clinic 4 months post-MI. Their blood pressure is sky high.
And the doctor is trying to figure out why.
Right. And it turns out they are only taking their daily metoprolol, their simvastatin, and their aspirin every other day.
Just rationing it out.
Exactly, to save money.
If we connect this to the bigger picture, we have to talk about the social determinants of health, or SDOH.
Right.
Because this specific patient is facing 4 massive systemic barriers that have nothing to do with their biology.
Let's break those down. The first one is economic stability.
Yeah. The medical bills and the out-of-pocket costs are just forcing them into medication rationing. You can't take a pill you can't afford.
The second barrier is healthcare access.
Right. What if they have to take 2 buses just to reach the clinic? The physical friction of just getting to the appointment is overwhelming.
And then there's the neighborhood environment. The scenario mentions they live in a food desert.
This is a huge one. They are relying on the local dollar store and fast food shift meals.
Because fresh fruits and vegetables are either unavailable or way too expensive.
Right. So their sodium intake is through the roof, which destroys their blood pressure and makes the heart work harder.
And the final barrier is social and community context. The text notes that the patient's family culture dictates avoiding doctors as much as possible.
So they don't even have that social support pushing them to go to cardiac rehab.
So what does this all mean? It means the most advanced cardiac catheterization, the most expensive troponin tests, they are rendered entirely useless if the patient can't afford the bus fare to rehab or the price of their aspirin.
It's sobering. And failing to manage this post-MI lifestyle leads to dire complications.
What kind of complications are we talking about?
Things like cardiogenic shock, where the pump just completely fails, or ischemic mitral regurgitation.
That's a brand new heart murmur, right? Because the valve muscle actually snaps.
Exactly. And, of course, fatal dysrhythmia is the electrical system just short circuits. It's deadly.
Wow. Okay, so synthesizing all of this, we've seen the clinical difference between an ischemic squeeze, the angina, and actual necrotic damage, the MI.
Right. The kink in the hose versus the dying grass.
We've learned about the deceptive nature of symptoms, especially in women and older adults. It's not always a clutching chest. It can be fatigue or back pain.
Remember the 15-minute rule.
Absolutely. We covered the timeline of cardiac enzymes, with troponin being the ultimate lie detector in the blood.
The gold standard.
We walked through the MONA treatment protocol, and finally the profound impact of social determinants on actual survival.
It's a lot to take in, but it's so important.
It really is. Do you have a final thought to leave us with?
Yeah, I do. We often think of heart disease as a battle fought in high-tech operating rooms, right? With ECGs and clot-busting drugs.
Yeah, that's the image we all have.
But based on what we've learned today, the true front line of this disease might actually be the aisles of a local dollar store, or the routes of the public bus system, or just the quiet conversations we have with our own relatives about health.
Wow. That is such a powerful perspective shift. Thank you so much for breaking this down with me.
Oh, my pleasure.
Excellent, and thank you for joining us on this deep dive. Stay curious, remain active, and listen closely to what your body and your community is telling you. See you next time.